Welcome to the Saving Lives podcast. I'm Joe. Today we're going to be discussing an article about cardiogenic shock, and it is titled Cardiogenic Shock in General Intensive Care Unit, a nationwide prospective analysis of epidemiology and outcome. It was published in the European Heart Journal, Acute Cardiovascular Care in 2024. As always, a disclaimer, this is not medical advice. You should really read these data for yourself. The article link is down in the show notes. Citation is. And before we dive into the article, a quick plug for my book, the Vasopressor Inotrope Handbook. Thank you for everybody who's picked it up. You can pick it up on Amazon or off of me directly from my website. But let's get started. So a couple key points from the study. First thing is we're talking about cardiogenic shock. And the thing about cardiogenic shock is that it has a very high mortality rate of about 50%. And this is something that we're trying to improve on. With different technologies, different shock teams, different medications, etc. And traditionally, the number one etiology of cardiogenic shock is patients who have a heart attack and acute MI, but more recent data is now suggesting that non-ischemic causes of cardiogenic shock is becoming more common. So the whole purpose of this study was to evaluate the epidemiology, I can never say that word properly, management as well as the outcomes of the cardiogenic shock patients. And this is pertaining to Italy. Perhaps that's why the title doesn't roll off the tongue. It was probably translated from a different language called Italian. I speak the third most Italian, by the way. So anyway, this was a prospective epidemiological study. I'm going to stop saying that word. And they were able to get all this information from a registry which encompassed 314 different ICUs in Italy. Now, the time frame here is very important. It's from 2011 to 2018 because we've made some progress in the course of the last 10 years, at least in the United States. I can't speak on behalf of my colleagues over in Italy, but I know there's some serious, awesome people working over there. From the general population standpoint, they looked at over 11,000 patients with cardiogenic shock, but they did exclude patients with cardiac arrest. The mean age was 72 years old, and approximately 62% of patients, 61% were male, given that, that distribution is not equal because males suffer from heart issues more than females. So the primary outcome that they looked at was both ICU as well as in-hospital mortality, and they had other secondary outcomes such as organ dysfunction, what type of treatments they used, as well as the length of stay in the ICU. So overall, out of all their admissions to the intensive care unit, their ICU admissions were only 2.17% of all ICU admissions was their incidence of cardiogenic shock. From an etiology standpoint, this is something that caught my eye. Again, I mentioned previously that cardiogenic shock secondary to an acute MI was the number one cause and historically has been. However, left heart failure encompassed 47.5% of cases of cardiogenic shock. AMI, acute myocardial infarction, was 32.6%, so it was less. Right heart failure was 4.6%, and biventricular failure was 4.8%. So again, left heart failure was the most common, followed by AMI. Now, from a patient characteristic standpoint, 47% of patients had more than 3 organs pretty much say they're not going to work anymore upon admission. The most common being respiratory, because obviously if the heart goes, the lungs are going to go right after at 88.7%. 67% of patients developed renal dysfunction. Obviously, if the pump's not working, it's not going to get blood flow down to the kidneys. Then they described metabolic as 53.3%. I guess these patients were acidotic, and that's how they were going down that pathway. And from a neurologic perspective, 21.2% of patients had neurologic dysfunction because of this. Now, the primary outcome was mortality, and the ICU mortality here was pretty high, at 44.8% of patients with cardiogenic shock ultimately passed away. I know that there's a lot of importance placed, and appropriately so, in some cases towards sepsis and septic shock management, but there the mortality is between 20 to 40%, depending on the paper you read. But here we're looking at 44.8% mortality for cardiogenic shock. This is something that we need to do better. Now, when it comes to in-hospital mortality, that number was even higher at 53.4%. That's a high number. But when we went ahead, and what I mean we? Like I wasn't part of the people doing this study. They actually teased out who were the patients who had the highest mortality, and it turns out that the patients who had RV dysfunction, RV failure, they had the worst prognosis. And then patients with biventricular cardiogenic shock also carried a very high risk of passing away from this. There were other risk factors that demonstrated high mortality. In other words, patients who had refractory hypotension, renal dysfunction, neurologic impairment, increased age also. These patients didn't do well. So, these patients, these little things, once you start knocking off other organs, things are just not going to be getting better anytime soon. From a treatment strategy perspective, 85.5% of patients ended up on the vent with cardiogenic shock. They were able to escape with 20% of patients approximately requiring non-invasive ventilation, but still most of the patients ended up on the vent. 96.5% of patients needed vasoactive support. In other words, they had vasopressors and inotropes applied to them, which, by the way, if you want to learn some more about it, check out my book, the Vasopressor Inotrope Handbook. And then from a mechanical circulatory support, we need to be aware that not every country has the same resources we have here in the States. But they found that the intra-aortic balloon pump was the most common used. And again, this is what they had available to them at approximately 16% of patients requiring a balloon pump. And this was highest in the patients after an acute MI, and there it was seen up to 37% of patients. They did have access to VA ECMO, and this was used in 1.5% of patients, but it was more common in the patients with biventricular failure. Now, again, patients with biventricular failure just didn't do well in this study. From a clinical implication standpoint, patients with non-ischemic heart disease, this was very eye-catching for me as somebody who just reads these data and tries to compare to what I see in my clinical practice. But it was important to see that there's been a shift, because we might be seeing this in other institutions throughout the country, throughout the United States, where there's a shift from acute myocardial infarction to decompensated heart failure being the number one etiology. The other thing is that when a bunch of organs start going, then the patient's likely going to pass away. Utilization of mechanical circulatory support, again, the balloon pump was more common in Italy. However, we have different tools, which I'm not going to mention in this podcast. And they also found that acting on these patients soon, in other words, admitting them to the intensive care unit early, led to better outcomes, where when you had a delay in ICU transfer, then these patients do worse. There are some limitations to the study. It's observational, it's retrospective. They didn't have swans in all these patients. They didn't have all the echoes for all these patients. It just reflects what's happening in Italy. But overall, I just thought that this was pretty cool, and I thought that it would be something that would be worth you checking out. So thank you for supporting the Saving Lives podcast. Hope you guys have a great day. Bye.